Thank you very much. So these presentations are all open for discussion now. So while we are waiting for questions from the floor, we have some questions online. So the first one is for our surgeon. So the question addresses the timeline of these 3D models. So do you envisage that there might be a delay in bringing patients to surgery if this goes through, clinical practice?
No, so actually the company have a turnaround time of about 2 weeks, so it's actually quite quick.
Okay. Yes, Shay.
So Arjun, really interesting talk. I have a question, which is about if I was thinking from the patient's point of view, if the technology in the 3D model says that it's inoperable, but you don't operate, how are you going to know if that was accurate or not?
That's a very good question, and actually that's why we haven't, for the proof of concept study, we aren't basing operability on the model. It's mainly, would the model have predicted it? If that is the case, then I think there's grounds for doing a proper study. But you're absolutely right. So that is the worry, that you trust the technology too much, indeed.
Could I continue the questioning there? And you may not wish to answer this, but what do, you produced your model, you've gone through the MDT. What do your radiologists think of that? Because the traditional 3D model is, we currently find in the radiologist's brain. They think in 3D. They can tell you whether there's some of them can tell you whether there's a tongue of tissue. Do they feel outraged by this? Do they feel
no, so in fact, it's a good question. In fact, one of the radiologists helped sort of set it up. And actually, he was the chap who, for the first patient who was inoperable, literally wrote in his report that he thought that the artery was clear. And so we took that back and said, look, this is what has happened. And no, they're very open-minded about it, actually. Yeah.
Yes, Simon.
Yeah, it's just a question for John, really. John, in terms of, from a hepatologist point of view, I mean, I think a bilirubin of 50, 60 in a cholestatic patient is very different to someone with parenchymal liver disease. And yet sometimes, mild dysfunctions in liver get in the way with chemotherapy and targeted things. How do you think we could look at that? I mean, do you think, what are these more targeted therapies? Because I'm not an expert in that area, but I was interested in the role of liver function and the preclusion of giving chemotherapy.
So we demonstrated a while ago that it's actually safe to give chemotherapy, standard chemotherapy, about 8. I'm looking at one to give me the correct dates here, but probably about 10 years ago, we published that chemotherapy is safe, indeed beneficial for people with bilies, up to 100, 200, and can reverse that situation. There's no real data out there to show how safe some of these targeted therapies are in the context of liver dysfunction, borderline liver failure. I'm constantly on the phone to the hepatologists because increasingly with our patients living longer with these targeted therapies, more and more patients are becoming unwell from liver failure rather than from the cancer. So it's moving into a similar situation that HCC has been in for some time. And I'm sure there will be development of a data set of people with liver dysfunction. Just off the top of my head, the antibodies should be safe. It's the small molecules that are going to give you the problems in the liver.
How do you think you get from standardized message out? You do get different things.
So this is the primary AMMF message that that needs to get out. I am asked on a weekly basis by patients, by colleagues about giving chemotherapy, and my bilirubin is high, they're not going to give me any chemotherapy, and I have to send them the paper that we published almost 10 years ago. So there's a gap in the knowledge. And this is one of the reasons why we're here. It's the primary AMMF message: get the information out there, because people don't know all of it.
I think Johan maybe wants to comment on this, and if I can just add a comment also. I think it's not only a level of bilirubin, it's just, how the patient, the comorbidities and the general fitness as well. Johan.
Yeah, thank you. I just wanted to follow up on that comment, the paper that John's referring to. It's not just about having a raised bilirubin. You're absolutely right, Chiara. It's why it is elevated and what the clinical picture is. So what we found in that paper, if the bilirubin is high because the disease is growing along the bile ducts, along the tubes, then you can give chemotherapy, because by reducing that swelling of the bile ducts, then the bilirubin improves. We found that the patients who did not benefit were patients who had lots of disease within the body of the liver itself, and that was the reason that the bilirubin was abnormal. So it's not just about the bilirubin itself, it is about the pattern of the disease as well.
Thank you. And we have another question from the other microphone.
Hello. Just a silly question for Professor Bridgewater. Is the gene that is targeted by the immunotherapy that of the patient or of the cancer itself, which will be found by a biopsy? Silly question, but...
It's not a silly question, it's an excellent one, and the answer is both. So about 1 in 3 patients with this mismatch repair deficiency will have some form of something called Lynch syndrome, in which the whole patient has this abnormality. Every single cell in the patient have this abnormality, and there is also a risk of it being transferred through the family. 2 in 3 patients do not, and it's purely a problem with the cancer itself.
Thank you.
Thank you. So I have a question for Doug. So in the UK pilot study, you have mentioned cytology first, and potentially even in US FMB. And I think that we know that the Mayo Clinic has pioneered the study. They have been very, very keen not to go for the US FMB for the risk of seeding. Do you want to comment if we really have data about the seeding risk, or if you are linked and bound to some old beliefs?
Yeah. So I wasn't involved in the conversation that led to those recommendations, but I think Simon may have been there and when it was discussed, for example. But I think the data from there was a meta-analysis of outcomes that was published in Edinburgh, and they looked at the patients who were transplanted within criteria without neoadjuvant therapy and those that were transplanted with neoadjuvant therapy. And the ones that were transplanted without, it was about 98% of them that had cholangiocarcinoma. So it kind of shows that the sensitivity of the criteria are pretty good if you use the Mayo protocol. But in the Mayo protocol, it's around 40 to 50% of the patients that come out and that have negative histology, and that's always been a concern to people, that you're exposing people to chemo radiotherapy and you haven't, and that's not the approach that we undertake in oncology otherwise. Yeah. I suppose this is a starting point for these pilots so that we ensure that we're including people that we've got a confirmed diagnosis on, given that the whole approach, I suppose, is experimental, including the proton beam therapy. Yes. And if we can demonstrate the safety and tolerability and feasibility in that set of patients, then there is obviously the opportunity for evolution and based on the much wider experience from the Mayo.
And do you think that if the patient has a PSC, we might need to be more relaxed, as the patient might benefit anyway from the transplant?
I guess the PSC patients in the UK are predominantly transplanted for liver failure. There's a lot of people, a lot of countries where PSC is, the indication for transplant is now quality of life, say, or biliary dysplasia. These are different things. So I suppose in the PSC CCA group of patients, we're transplanting them for cancer, and I think we should confine our decision making to, do we think this is a cholangiocarcinoma that would fulfill the criteria, and therefore that we anticipate we could get a favourable outcome from.
Thank you. We have another question from the floor, and then we have some more questions online.
So I just had two questions. One is in terms of transplantation, is your immunosuppression going to be exactly the same if you transplant for cancer compared to non-cancer indications, or are you going to try to reduce the immunosuppression? Or would you just immunosuppress as you would for someone for benign disease?
Yeah, that's a good question. I mean, we obviously, about 20% of the waiting list at the moment are patients with hepatocellular carcinoma. So we are transplanting patients with cancer indications. So paradoxically, sometimes they're fitter than the other patients and maybe more immunocompetent than some of our patients with advanced liver disease. So it's very much a kind of individualized approach, but there isn't within the protocol a planned reduction in immunosuppression for these patients. I think it's just going to be standard in immunosuppression according to the protocols of the individual centres. But as a general point, a lot of effort is put into minimising immunosuppression. And if you look at the immunosuppression that we use in liver transplant compared to other organ transplant, it's considerably less to start with.
The second question was a very probably old-fashioned question for Professor Bridgewater is, with all the new treatments available, is there any clinical marker to select someone who may benefit from second-line FOLFOX or CAPOX? My thoughts are, if someone's progressed very rapidly, very symptomatic, realistically, would you still offer it? And also the supportive care arm in that study did quite well as well. So how do you select someone who may benefit from the second-line FOLFOX clinically?
That's a really good question to which I don't have a great answer, I'm afraid. There's no clear selection for somebody who will benefit from FOLFOX. It's a modestly beneficial treatment at best, and you know, if possible, we will offer an alternative, a targeted alternative, because you know it is not great treatment. It's all that we have currently. It is the international standard second-line treatment, but it's pretty modest. We don't really have any criteria to select a patient who will benefit.
And there are a couple of online questions as a follow-up on this. So one is about the indication of these targeted therapies for cholangiocarcinoma patients. Do we need the trials in cholangio patients, or can we access them if they have been approved for other tumor types? And given the rarity of cholangio, you know, to make the clinical trial more feasible, is there an initiative to expand the access of patients to targeted therapy, to clinical trials with targeted therapies in, you know, Europe and internationally?
So this is the big question all around agnostic treatment versus cancer-specific treatment, and the argument goes on for days. The agnostic treatment means that if you have, for instance, a HER2 abnormality, if you're a breast cancer patient, if you're a colon cancer patient, if you're a cholangiocarcinoma patient, the agnostic argument goes that your drug, for instance, the AstraZeneca drug, and HER2, and HER2 therefore works in all of those cancers, and you have what we call a tumor agnostic label for the drug, which means that you know once it's signed off by the MHRA and the various authorities and by NICE, everybody with a HER2 abnormality, no matter what cancer, can get the drug. That's really attractive for lots of reasons. It means that people with rare cancers can get access to these drugs and benefit from these drugs. There are some big concerns about whether tumor agnostic is really true. There are various definitions of tumor agnostic. One of them is that it should work in at least, I think, 16 cancers, something of that order. But unquestionably, it works better in some cancers than others. So tumor agnostic is a nice idea it gives access to the drugs for people with uncommon cancers. It's probably not actually true. There's no such thing as tumor agnostic. Some tumors are definitely more sensitive than others. So I've very mixed feelings about that.
John, can I ask a question? So if I was a patient with cholangiocarcinoma, or someone I loved had cholangiocarcinoma, and they're unable to access trials where they live locally, how feasible is it for them to partake in a trial in another city?
That's dependent on so many things. Primarily how willing the patient is. Many people travel great distances for studies. There's a slight and there's a huge literature out there looking at the cost of travel, the time taken with travel, the impact that has on the patient, compared to the potential benefit that the patient would have going on the clinical study.
But it's worthwhile them looking into it. And
yeah, absolutely. I mean, and it also depends on the treatment. So some of my trial treatments are tablets, and people fly in from all sorts of places, even some places abroad, fly in, pick up their tablets, go home for 3 weeks, come back.
Then obviously, when we are considering access to clinical trial internationally in European country, we are all different legislation in each country, so it's more difficult to do it as part of a
Some are easier than others,
sector.
that's for sure. Yeah.
We have an extra question for the surgeon. So if you think to bring this model into the clinical practice, you're going to make an economic case discussion for how you include that into the decision algorithm for surgery.
Yeah, so
Is the
like-
cost increased with this?
indeed, I would suggest that doing a cholangiocarcinoma operation is an expensive sort of task anyway. They have intervention radiology, endoscopy in some instances. They have to have the future liver remnant grown, etc. So I think, so it's £1,000 at the moment to print one of these models. As with everything, there's no panacea. It would help in decision making, but would not be the make or break. So it would help, but we wouldn't say to you that this is the thing that's going to absolutely change sort of cholangiocarcinoma surgery. But that's just never the case.
And there is a question about what you just mentioned about liver remnant function. Is there a specific protocol to assess it, or is there any research?
So
about
I
it?
think I don't think there's a standardized protocol across the country, but most units will have a set of protocols that they use. Our own radiologists have a bit of software where they can tell us what the FLR will look like. Pretty sure it's the same across the country.
Thank you. Oh yes, Professor Davidson.
A question and a comment. First of all, Doug, I think you didn't quite mention about the central review process for discussing cholangiocarcinomas considering for transplantation. I think that's a very, very important aspect of the algorithm. So perhaps you could just clarify about the central review process and whether or not there is an arbitration process for any disagreements. That's the question for you. And Arjun, the comment for you is, I think it's very interesting what you've been doing. We have had a different approach along the same line, as you probably know.
Yeah.
We have developed an image guidance system from scratch through funding from the Wellcome Trust and the Department of Health, and that is now in pilot in our centre, where we take the preoperative imaging, produce a model, and then overlay it laparoscopically on the liver at the time of laparoscopic liver resection, and that will just be about to start a clinical trial, NIHR funded, at the end of this year.
I would definitely like to get my hands on that once that's done.
So briefly about the national review process. It varies for each indication. So for the neuroendocrine group of patients that I mentioned, there is a national MDT, and they decide which patient might be suitable to take forward to transplant and what might be required to get them into the space that would allow a transplant to be undertaken. For cholangiocarcinoma, it's not proposed to be the same. There's more of an advisory and supportive group, such that, and a lot of the responsibility will be held with the individual local MDTs in the transplant centres and within the cancer MDTs. But there's always, there's a learning curve for everyone around this. And it's good if there's an opportunity for difficult cases to be brought forward for that experience to be shared amongst all of the centres. So it's based on that principle rather than some kind of stipulated assessment.